Hello, welcome to our GI pharmacology lecture where we are going to discuss the beauty that is diarrhea, constipation, vomiting, and inflammatory bowel disease. Here's the outline. We're just going to understand how diarrhea and constipation works, how inflammatory bowel disease works, and we're going to learn how to treat these symptoms associated with those diseases. Let's talk about diarrhea and emesis. There are two main types of diarrhea. The first one being secretory. Secretory usually started by GI irritation. Now this GI irritation will then cause two things. It'll cause an increased secretion, which will cause an increase in filling, and it'll also trigger the enteric nervous system, or the myenteric layer, or the Auerbach plexus. So this causes the peristalsis, and that causes a whole lot of diarrhea, secretory diarrhea. You see this a lot in inflammation, like in the presence of C. diff or a toxin or inflammatory bowel disease. So that's secretory diarrhea. Let's talk about osmotic diarrhea. Osmotic diarrhea usually means that there's something not being absorbed. Doesn't matter what it is, there's just something that's not being absorbed and it's building up in the lumen of your GI system. Now, if it builds up in the lumen, what happens is water is going to try to follow down through osmosis, and it'll cause a whole large volume diarrhea to come out. Something you do need to know as a side note is whenever you do get irritation, both of which can really cause irritation, secretory more though, more than osmotic, but both will cause irritation, and this will actually trigger the enteric nervous system, the Auerbach plexus, and this can cause an increase in peristalsis or hypermobility. So let's move on and talk about nausea and emesis, which requires a brief introduction to neurology. Inside of your brain, you do have this little chamber called the fourth ventricle. This fourth ventricle has a little area at the bottom of it called the area postrema. It's called postrema because it's at the back of the or the posterior of the brainstem. This area postrema is very well connected over here with the vomiting center, which is a part of your medulla. It's actually a very primitive part. One of the first things that an organism needs to know is that if something is going to kill it, it needs to be able to throw it up. Or if it's eaten something poisonous, then it needs to be able to throw it up quickly. So let's talk about, there are a lot of receptors here, but we're going to focus on two for the most part. Dopamine, okay, is going to be found in the area postrema. And if dopamine is found there, it'll bind onto D2 receptors. These D2 receptors will then send a signal to the vomiting center. And this vomiting center will cause lower esophagus relaxation. So you've got your esophagus right here. It's relaxed. And it'll cause retrograde peristalsis. So you're going to get up and you're going to throw up everything that's inside of here. So what you do need to know is that dopamine is mostly the upper GI. Its effects are mostly limited to the upper GI. Now serotonin, that's going to be associated with upper and lower GI. Any form of irritation in your GI system will cause neurons, more specifically the vagal nerve, to be activated. Right, so this irritation will cause a release of serotonin, and the serotonin will go to your vagal nerve, and this vagal nerve will actually go directly to the vomiting center. So you get a direct connection to the vomiting center, which then triggers nausea and vomiting. Let's talk a little bit about laxatives now that we understand the basic physiology underlying all of this. So laxatives, of course, there is milk of magnesium. I've shown you a picture of milk of magnesium, also known as magnesium hydroxide. And there's also magnesium citrate. When you become practicing physicians, you're going to be prescribing this a lot, especially if you're in pediatrics, because kids get constipated all the time, almost on like a monthly basis. But the mechanism of all of these are pretty much the same. They're poorly absorbed, so they stay in your lumen, and they increase your osmotic load inside of your lumen, so you get loosening of the stools, and you prevent constipation. It breaks up all of this poop, and that way you can have nice flowing poop out of your GI system. It makes defecation a lot easier. It's used for constipation. Something you do need to know about one of these is that lactulose is different. Lactulose can actually be used for hepatic encephalopathy. Now, why does it do that? It actually breaks down in your colon and it causes a whole lot of acid to build up. All right, so that means you get a low pH. Remember, in the presence of a low pH, all these hydrogens are going to try to be interacting with bases. So these in the meantime, gut bacteria is producing a whole lot of ammonia. So hepatic encephalopathy, you've already got a bunch of ammonia. And if ammonia is not charged, it'll be absorbed. But since there's a whole lot of hydrogens floating around in the presence of lactulose, what's going to happen is that this is going to turn into ammonium, and ammonium is much less likely to be absorbed by your GI system. So you don't get an addition of ammonia. And your liver, your poor liver, is probably failing right now. Doesn't have to worry about detoxifying so much of the blood that is coming in through the portal vein. Of course, the adverse effect is going to be diarrhea. That's kind of the intended effects, and dehydration. That's of course you would expect that with. All right, let's talk about Orlistat. Orlistat just means oral lipase inhibitor, or Orlistat. I've showed you the chemical component so I can remind you that it kind of looks like a monoglyceride. If you remember how a triglyceride looks like, it's just over here. And the lipase was responsible for cutting these off so that you can go from a triglyceride to a monoglyceride. Remember, triglyceride cannot be absorbed, and you need monoglyceride to be absorbed by your gut. So if you inhibit this lipase, you can't break down the triglyceride, so you can't absorb it, and you get weight loss because all the fat is just pooped out with defecation. So of course we're going to use this as a weight loss aid, but what you do need to remember is that you need some significant lifestyle and diet changes first. Because for the most part, this just reduces the amount of fat that you absorb by about 30%. And you can't really just take higher doses. It doesn't really work. Higher doses doesn't mean you get more effect. It kind of plateaus at 30%. So you need to encourage lifestyle and diet first. I showed you a picture of Ally, which is the brand name here in the US for Orlistat, and I've showed you a picture over here of weight loss program. They use it as advertisement, letting you know how much weight you could lose if you were if you were on this magic pill. Now remember, the adverse effect is going to be steatorrhea. That just means fat, or steatorrhea, which means running fat in your stool, and it's going to be loose fatty stools that is floating in your toilet bowl. You could also get fat soluble vitamins deficiency, and these vitamins are pretty much anything but the B and the C vitamin. So anything but vitamin B's and the vitamin C. That's going to be A. That's going to be vitamin D, E, vitamin K, so on. All right, let's talk about loperamide. Loperamide, I just remembered as low and para. It lowers peristalsis. What you need to know about loperamide is that it is effectively an opioid, except the only difference is that it does not cross the blood-brain barrier. So if you've been gunning ahead, you'd probably know that opioids, the major side effect is constipation. This is actually the side effect from opioids that patients will never get over. So a lot of the patients that are on pain meds are often constipated, sometimes to the point that they need surgery or they need hospitalization of some sort. So the way it works is by being an agonist to mu receptors. It activates these mu receptors, which then goes to your enteric nervous system. For the most part, it inhibits your enteric nervous system and it reduces peristalsis, but it can actually increase segmentation. And so what that means is that your GI system has more time to absorb water and you get less diarrhea. So of course we're going to use it to reduce diarrhea. So over here I've showed you how peristalsis works. You're just constantly pushing on the food right behind it so that you can kind of like push it down, kind of like a tennis ball in some stockings, for example. Segmentation is more like karate chops. You're just kind of like segmenting over here. You're going to try to cut a stool and break it up into little tiny pieces. You can see it's kind of squeezed and it's broken up to little pieces until it's a lot easier to pass through. So this is not really going to allow them to move very much though, but it does give you more time to absorb everything because you're increasing the surface area. Now, the adverse effects of loperamide, you can imagine if you don't have any peristalsis, you can get constipation. Something else you need to know is that a little bit of it can cross the blood-brain barrier, but which part of the blood-brain barrier can it cross? The area postrema, the most fragile part of it. And the area postrema actually does have opioid receptors, and this can cause nausea and sometimes vomiting with patients taking loperamide. All right, let's talk about Senna. Senna is actually from a plant called Senna, or in Arabic it's called Senna alexandrina. And this plant over here is an ancient drug. It has actually started being used maybe 700, 800 BC by the ancient Egyptians, though. Those ancient Egyptians were actually some pretty smart folks, if you ask me. And how it really works is that it irritates your colon and it causes an increase in motility and secretions, or a secretory diarrhea. So the ancient Egyptians often used it as a mild laxative. It can also be used nowadays as a way to empty bowels pre-op. You don't want the patient pooping right after surgery when they're coming off of the anesthesia. That's actually happened to me before. So make sure you just give them a little bit of Senna beforehand if they haven't pooped already, and it'll get everything going. Of course, the adverse effects of any laxative is going to be diarrhea, but something that's unique to Senna is it can cause melanosis coli, or it can cause your colon to pretty much look brown, as you can see here. Nothing really bad about it, it just looks brown, and it can be surprising if you're giving someone a colonoscopy and you see something like that. Let's talk about sulfasalazine. Let's just look at the name. We see sulfa in the name, so we know that there's a sulfa group right here, and there's going to be salazine, which is going to be right over here, salicylic acid. So we know sulfa, if you've gone over the antibiotic section, we know sulfa is just pretty similar to PABA, which is eaten up by the bacteria. So what you need to know is that the sulfasalazine, while it's going through your GI and your upper GI, it isn't really broken down. But once it gets to the bacteria have enzymes that are trying to target PABA, but instead they target this over here, and then they break it apart. Now you have the sulfa inside of your GI, and you've got the salicylic acid, which is just only really activated once you get to the colon. All right. So this salicylic acid can inhibit the COX-1 and COX-2 pathways. You might want to review the immunology lecture about that. But in the end, you get a reduction in inflammation in your GI. So what that means is that whenever you have some sort of inflammation inside of your lower GI, inside of your colon area where the bacteria is to activate it, you can give them sulfasalazine. That means you could use it for ulcerative colitis, because ulcerative colitis always involves the colon, and you could use it for some Crohn's when you find Crohn's disease in the colon. I've showed you Crohn's disease, which shows you that cobblestone pattern right there, and I've showed you ulcerative colitis, which just shows you the broad inflammation all across the walls right there. The adverse effects that you need to know about sulfasalazine is going to be the sulfa allergy. If you remember, G6PD deficiency, very often found in Mediterranean people and Egyptians like myself, can put you at risk for a sulfa allergy. You can get hemolytic anemia because of the reactive oxygen species. You don't have G6PD to reduce the reactive oxygen species, so you get hemolytic anemia. You may want to review some biochemistry if you've forgotten that. Now let's talk about Ondansetron. Ondansetron has cetro in its name. I remember SE stands for serotonin, and TR stands for 3 or tree. If that works for you, you can memorize it like that as well. I remember that it inhibits the 5-hydroxytryptophan 3 receptor, or hydroxytryptophan is just really serotonin receptor, because serotonin is derived from tryptophan. So this causes an actual decrease in vagal stimulation. If you recall, the serotonin is caused by irritation of your GI system, and then it'll trigger your vagal nerve, which will go directly to the vomiting center and cause you to vomit. So if you inhibit this serotonin receptor, you don't get this activation of the vomiting center, and you get less nausea and vomiting. This is very, very often used, especially when you're working with chemo patients, just nauseous patients in general, or post-op patients. Sometimes, as you can remember, the opioid receptors inside of your area postrema can sometimes trigger your vomiting center. But this over here kind of reduces the amount. And with chemotherapy, chemotherapy is pretty much poison that you're putting into your body, and of course it's going to irritate your GI system. So when you give them Ondansetron with chemotherapy, it can reduce the nausea and vomiting associated with that. It can cause QT prolongation. Here's what to remind you what QT interval is, and if it gets too long, you can have torsades, which can then progress to VTAC and then cardiac arrest. Let's talk about metoclopramide. Metoclopramide works by inhibiting the D2 receptors in the area postrema. So if you get an inhibition of the D2 receptors, you don't get an activation of your vomiting center. All right, if you remember how dopamine usually worked, is that it reduces your lower esophageal sphincter and it causes retrograde peristalsis, so you can throw up all the contents of your stomach. But when you're taking metoclopramide, what that does is that it inhibits the effects of dopamine, so you get a tightening of your lower esophageal sphincter and you get anterograde peristalsis of your GI system. Now, something you need to know is that it's used for to prevent throwing up, of course, GERDs, because it's just acid being refluxed back out, and gastroparesis, which is often seen in diabetic patients. People with chronic diabetes can have peristalsis or gastroparesis of their stomach, and it can also be seen in patients who have recently taken anesthesia. They can also have a paralyzed stomach. So you give a metoclopramide to get things started. The adverse effect is going to be the same mechanism as before. It inhibits the D2 receptors, but instead of the area postrema, it actually inhibits it in the putamen. It kind of crosses the blood-brain barrier a little bit, and this can cause Parkinsonian effects. Here I've showed you a picture of the brain, and I've got an arrow right here to the putamen. The putamen is the area of the brain that's underneath the caudate nucleus and around the globus pallidus. You'll get this in much more detail when you take the neuromodule. Now, Parkinsonian symptoms, the way I remember it is by remembering the mnemonic trap. They get tremors, rigidity, akinesis or bradykinesis, which just means slow movement, and postural instability. They feel very unstable on their feet, and they're shuffling their gait. They actually have a problem moving a lot. They can't control fine motor movement, and in severe cases of Parkinsonian, they can barely move at all. Okay, let's talk about Ursodiol, which is just basically colic acid. It's derived from two words, urso, which is Latin for bear, and diol, which just means two hydroxide groups, because it is an analog to colic acid, which has two hydroxide groups. So this is actually a secondary bile acid, and so when it gets into your gut, it actually is resorbed by your gut, and then once it gets back to your liver, it gets a sulfur added. So then it goes from secondary to tertiary bile acid. And these are extremely soluble, so that when that's excreted into your gallbladder, it can actually dissolve these stones. When would you use this? It's really only used when you have kidney stones, but surgery is not indicated and not wanted. So for a quick history lesson, this is actually has a very inhumane background. In the past, when we couldn't make these in the lab, what we actually did was we captured a lot of these Asian moon bears, and these Asian moon bears were kept in small cages, as you can see over here, and every day or every 2 days, these bears would be put under anesthesia. Someone would take a hole or a needle into there and find their gallbladder using an ultrasound and take out the Ursodiol, and then this would be purified and marketed for human consumption. I've also showed you on a little lighter note Ursaring, which is a Pokemon that is based on the moon bear that you find in Southeast Asia. So how are you going to use this information? The mechanism and the adverse effect, as with pretty much all the drugs that we talk about, are extremely important because mechanism can test your physiology and adverse effects can test your clinical skills. Now, GI pharmacology is an excellent time for you to start thinking more systemically. I'm trying to point out now a little bit more of how each drug is affecting another system in your body so that you can take that as a hint to kind of study and make connections. For example, sulfasalazine can be used as a gateway to study the immune system, maybe a quick review to see how that works, how aspirin works. And metoclopramide can be used again when you can go back and review it when you get into neurology, or you could read ahead. Who knows if you're ambitious enough. All right, I hope that was helpful and good luck.